great to see you again, Karen.
Good to see you too.
I wanted to just have us kind of drift back real quickly here. I know this is about stories, and my story is when I first met you, and it was at the dedication of the Thompson building in Davis, and she introduced us, and what a great way to have a mutual connection, Helen Thompson. But I'm sure that your involvement, I think you were the behavioral health director at that time. Your involvement probably goes way back beyond that. And so why don't you tell us a little bit about how you got started and ended up there that day?
Yeah, I feel like, well, first of all, when I was 19, I picked up a felony and related to my substance use. And uh, I was lucky enough to have parents that could help get me out of that situation. I got sober, and, you know, the short story is that's how I ended up in this field. I have done my best to give back to the world ever since that time. I have a lot to be grateful for. And as I kind of went through this field, I feel like each of my roles, like it's a series of concentric circles. I started out working in drug treatment because that's what you do when you first get sober and want to help others, and kept going to school, had a few kids, got my master's degree, um, and so I went from being this individual therapist, and then I was like a manager, and then a supervisor. I worked in community clinics for about 20 years, and uh, and in Yolo County, which is where we met, I had worked at this community clinic for about 15 years. And we had been through 8 mental health directors in that time for the county. And each one of those mental health directors, in my humble opinion, was worse than the one before them. And so they asked me to be on the interview panel for that position, I think kind of to shut me up. And so I sat through 8 hours of interviews, and I said, oh my gosh, you can't hire any of those people. They're just awful. And so they said, well, why don't you come to work for us? And so they were getting ready to integrate behavioral health, public health, and social services, and that was really attractive to me when I think about the safety net population and what they need. And so I said, okay. I joined the county. We integrated those 3 departments. I was over the kind of adult services, so it was homeless services, all the mental health services. And um, not too long into my tenure, the director of the agency was let go unexpectedly. And the CIO called me and said, you want this job? So
Okay.
then I ended up as the Health and Human Services Director, which was just, I mean, I always talk about Yolo County. It was like the Goldilocks County. It was not too big, not too small, just the right
Just right.
size. And I mean, with people in the county who had been there for decades, like Helen Thompson and her husband Cap, who was the first mental health director the year before I was born in Yolo County. You know, you have this like through line with the individuals there. So for the 20 plus years I worked in Yolo County, I saw multiple generations of clients, and I also had this consistency of the partners around the table, and just a beautiful experience. And, you know, I did that job through COVID. So I was over public health, social services, behavioral health through COVID, and it was a lot. It was really hard. And so now I have this statewide lens. I've, you know, transitioned from Yolo County into this statewide lens, and it's, you know, been a great transition. I'm at a great point in my life in terms of my age and like the retrospective of all these decades of experience, and feel like I, you know, landed in the right place for now.
Yeah. So you were at the community level, hands-on with people, knowing probably a lot of the clients personally. And so you bring that with you today, knowing what it's like to have statewide focus, but individual kind of impact.
Yeah, I mean, I think the uh, gift, or maybe it's a curse, of being in a county like I was for so long is that I uh, watched little people who we like had their moms in treatment, for example, and the little people would come to treatment with their moms. They were involved in child welfare, and I watched those little people grow up and enter my juvenile justice system, and grow up a little more and enter my adult criminal justice system, and then grow up, you know, have their own kids who, you know, and just those multi-generational patterns really solidify why you do this work. And I know those patterns play out statewide. And so try and, you know, there's definitely some faces that I carry with me all the time when I'm making decisions and kind of think about them as we're trying to chart a course.
Sure. So you can trace the trajectory of people's lives in the system that you managed. And what's that like, feeling responsible for the lives of people and trying to help them and support them in ways that are really meaningful?
Um, I mean, it's some of the best parts of my life. I mean, it's a lot of responsibility. I mean, I think about living through COVID and being over a, you know, being feeling responsible for literally life or death decisions that you're making at a county level. And while this position that I'm in now at the Steinberg Institute is a little more macro in nature because it's statewide, you're still ultimately, trying to improve life outcomes for people that live with behavioral health conditions. And we know our people die, on average 25 years younger
Hmm.
than people without these conditions. And so, um, while maybe I'm not like in the day to day a specific person making a specific decision, I still like appreciate the gravity of the decisions that I make or the things that we advocate for or against.
Yeah. One of my mentors actually talked a lot about remembering the people behind the figures. I chose a different path than you did, legislative action, and the man that I work for was always reminding people that this is about people. It's about individuals, and that's a really nice focus to be able to bring into a statewide perspective and to try to kind of push systems to do better by them.
Yeah. 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 I think, we had this framework that we used in YOLO called the results based accountability framework. And it was kind of a different way to tell the data story. So we talked a lot about like how many people you served, how many services they got, those kind of traditional things that we talk about. And we talked about how well the system did, like access to care or, things like that. But the thing I loved most about that, the way we looked at outcomes is like at the gold standard was, is anybody's life better off as the result of what you've provided for them? And so I think about that a lot in this position because our state's not very good at proving that our people's lives are better off as a result of the services they receive from us. We just don't do a good job of tracking those outcomes and telling that story. And so I try and, we try and push for that in the things that we advocate for and against.
Okay, so bringing the story forward, is that one of the things that the Steinberg Institute, with your leadership, is trying to do? Is trying to shed a light on the circumstances, kind of more as systems of care that are taking care of people by getting more data and getting outcomes established. Is that part of what you're doing now?
Yeah, 100%. I think, we were founded about 10 years ago when our founder left the legislature and he said, I want to keep working on behavioral health. And nobody's really paying attention to it at that time. And so, fast forward 10 years and the budget here in California for behavioral health has more than doubled. The pieces of legislation have grown by more than 800 times. And we like to take credit for a little bit of that. Sure, the governor has something to do with it. He's very interested in behavioral health. But the reality is, despite that infusion of resources, our access to care hasn't improved at all. And so, and access to care is not even like, is anybody's life better off? Because you could get access to bad care and your life would still be pretty bad. So
Yeah, yeah.
it's like, so yeah, we focus on like, can we tell the story about outcomes? Can we focus on outcomes and move our systems forward to achieving those? And uh, our our Vision 2030 initiative, our current initiative, is focused on reducing hospitalization, incarceration, and homelessness for
Mhm.
people living with behavioral health. So that's all about those systems. Um, and and we have to talk about the behavioral health workforce because it's needs
Absolutely.
so much
Yeah.
support. And so that's really what we're keenly focused on is those kind of four pillars in terms of and the outcomes within those four
Hmm.
pillars.
Okay. So where you are now, are you feeling optimistic? I mean, you've established domains where you want to see improvements. And I know the Steinberg Institute is pushing in a number of those, if not all of them. So, is there a reason for us to hope?
I have, much to the chagrin of some of my colleagues, I'm always very positive. It's one of my, I think it's probably annoying to some because it doesn't feel like I'm a realist in our current environment sometimes. But um, I always feel hopeful. I mean, we have so many um, transformational things happening in behavioral health in California right now, um, that I have hope. If we can implement all of those things in the way they are written and envisioned, it'll be an amazing day. I also am worried with our current, federal administration and some of those threats. You can't deny those. And just the budget, and there's going to be a new governor here before long. And the next governor is probably not going to have behavioral health as a priority. And so I try and temper my positivity with
Okay.
reality.
All right. So, one of the things I wonder about sometimes, because I've been involved in my level of activity for a long time. And what I guess I've learned, and I want your response to this, is that implementation is a bear, that you can have good policy, good vision, good focus, good values. And then at the end of the day, you've got to actualize those,
Hmm.
right? So that's and could you say something about where you think you are and the Steinberg Institute is about that?
Yeah, I mean, it's actually, I think, why our board of directors created the CEO position. We'd had an executive director for our first 7 years, and we're almost entirely focused on policy. And I think they came to this realization that passing good legislation in and of itself doesn't actually transform all that is broken in our behavioral health system statewide. And so they created my position. We've added this public policy research arm to the institute, and then are at the same time adding this implementation arm. Um, I mean, we passed the parity bill several years ago. We're so proud of it. It's probably one of the strongest in the nation. And it's we're we're several years past that, and the implementation is just continuing to falter. And I could have probably several full-time people just ensuring that the state is doing what they are supposed to be doing to implement that the way it was intended. 988 is a more recent example.
Sure.
One of
Mhm.
another one of our proudest moments is when 988 passed, and this vision for this robust crisis continuum. But, like, getting from where we are today to what the vision is of that is gonna take a lot of time and effort and energy and advocates pushing the state
Mhm.
to move
Yeah.
those systems forward.
Yeah. I just saw regulations by DMHC for the Department of Managed Healthcare for the 988 system, and I thought, wow, it's nice to see something happening there. Hopefully we'll get there sometime soon.
Mhm.
I know we have a system that we've talked about, trying to help coalesce around a kind of a uniform, comprehensive response to crisis statewide. And then 98 came along, and we have the vision, right? And now it's still really all shoulders to the wheel to make that phone when somebody makes a phone call, to make sure they get the right kind of response from the other end. When they need more than that, they get more than that. They get somebody maybe to come
Mhm.
see them,
Mhm.
and then a place to go
Yeah.
afterwards.
Yeah, and I think what 988 and several of these statewide initiatives have highlighted for me is the diversity of California, and not just the population, which, we're so lucky to have such a diverse population, but like California itself, Del Norte County up on the far north is got totally different challenges than LA, which is like a third of our state. And so things like mobile crisis response are going to look really differently in those small rural counties than they do in our big urban cores. And legislation isn't always written that way. Like, they're
Mhm.
like, "This is legislation. This is the way it's gonna be in the state of California." And so I think, balancing the needs of the different sizes and complexities of our counties is really important when we're moving towards implementation.
Yeah, I've heard at least one governor say we're ungovernable just because of the immense differences from one part of the state to
Yeah,
another.
yeah.
So that's part of the challenge. How do you do that when we're basically another country? Um, So here you are. What are you looking forward to? What are kind of next steps? Where are you going? Um, and so I suppose that also means where the Steinberg Institute is going.
Yeah, I mean, I kind of mentioned our Vision 2030. That's like our guiding star for everything we're doing, whether it's the research arm that I talked about, or the policy, or the implementation. And um, the way we're envisioning the research arm, for example, is not like subject matter kind of research, brain science, and things like that. It's like population health kind
Hmm.
of public policy research. Like, can we take things that are already publicly available, perhaps, and tell a story, or can we dig in with counties about certain data points and try and inform uh, the implementation of some of these big projects and or uh, initiatives?
Okay. Could you give us an example?
Yeah, I mean, currently, we're working on a big public policy research project around behavioral health workforce, and we were lucky enough that it kicked off at the same time HCI was doing a big workforce. So they kind of did quantitative big data stuff, and we did more of the qualitative, like we did focus groups and convenings and surveys with all different provider types, and kind of are digging through like what are the common challenges. Most of us know what those common challenges are, like pay and um, burnout, caseloads, those kinds of things. But we definitely have learned a few nuanced challenges that maybe we hadn't heard before. And then what are the solutions, right? Like that the providers see or that other stakeholders see, and those are things like building up our peer workforce, our people with lived experience, um, looking at the role of technology in addressing the behavioral health workforce
Hmm.
challenges, and collaborative care models, and ensuring that the folks that are going into their primary care provider can also receive behavioral health services if they so choose, to kind of help with the stigma, grows the workforce beyond just behavioral health. Um, those are, that's kind of the current research project that we have going on. We have another one that's kind of looking at the different levels of care available, and hopefully we're going to crosswalk those two together. So we'll know what the workforce gap is, and then we want to know what the community based services gaps are, and see if we can meld those together
Hmm.
and figure out where are we really
I,
with
I was
community mental
I
health
was
and
just going to
substance
ask
use
about
treatment.
the other side of the coin is, where do people go for services? Are we building enough of the right kind of beds? Do we have enough residential capacity for people in the community? And I think you would agree with me. The answer to that is no right now. But what are you and the Steinberg Institute doing to kind of focus on that and drive that forward?
I think because like our Vision 2030 is so focused on reducing system involvement, that hospitalization, homelessness, and incarceration, we've been focusing a lot on full service partnership, that piece of Prop 1 and the behavioral health in the public system. Um, we feel like there's an opportunity to get back to the original intent of FSPs, to focus on those people who are, seriously mentally ill and or have co-occurring disorders, and are chronically homeless, are coming out of a carceral or other locked facilities, had multiple hospitalizations or arrests in the prior however many months, and support those folks with those wraparound services, so we keep them from cycling through the higher levels of care um, that aren't good for anybody.
Okay. All right. So what do you do to take care of yourself? Let's switch
Oh my
gears, go to
gosh.
the personal.
Yeah. Um, I spend time with dogs.
Oh, nice.
This
Okay.
dogs, I mean, that's, like they are just the ultimate unconditional lovers. Um, I
And they
have
can be our better natures too
Yeah, I mean,
sometimes. Yeah. Yeah.
yeah, they don't talk back. They're easy to be with. I try and, walk a lot, and I drink a lot of water, and, do my best to take some mindful moments as I can through the craziness of our work. I have 3 kids, and that helps,
Okay.
spending time with them and the people I love, and 'cause, it's like we don't just have work. We have, I have aging parents who I'm trying to take
Sure.
care of, and then I have my kid, it's that sandwich generation, so I
Mhm.
do my best to just try and spend time with, people and creatures that I love and care about to fill my tank.
It is interesting that one of the things that you decided to do with Steinberg Institute resources is develop a research arm. So first of all, what is that about? And then, maybe we can get into some examples.
I mean, ultimately, I think it was born out of a frustration with the state to about telling the outcome story. We did one of the things our research team did was this document called the No Excuses document, and it basically is like 13 pages that we sent to the state. These are all of the things that you collect from counties or the systems on a regular basis that could be used to tell outcome stories. Things like CANS data, which is collected on every youth that enters our public behavioral health system. Um, uh, Things like the FSP data, for example, that every county submits regular updates to. And the feedback we've always gotten is like, well, the data is so bad and we can't really tell that story. So I think that really, that, like
It was a
frustration with
motivation.
the
Yeah.
inertia of the state and just like it moves at a glacial pace, and we're such a huge state that I'm sure that those are very real challenges, and we can't continue to say we don't have the data. And if we don't have the data, how are we ever going to make sure that we're making people's improving the outcomes that these people's lives?
Hmm.
It's billions of dollars that are being invested, and we can't say to what end. And
Hmm.
that's frustrating.
I remember when I started out, it's like, well, we don't have the data, but let's go ahead anyway and see what happens, right? And that's kind of a poor way of going at it. It doesn't necessarily yield good outcomes. S- So, um, so data was part of your. I mean, it's really kind of a foundation for the 2030 vision, right? Because how can you do something in all those areas with homelessness and incarceration, and if you don't have the data to kind of point the way, right?
Yeah, and I think, you know, I don't ever want to represent that mental illness or substance use are like that is the homeless problem, right? There are plenty of people who live outdoors and were not mentally ill or struggling with substances before they got outdoors, right? Like life happens and bad things happen and people end up outdoors. If you're out there long enough, you're going to have some pretty significant behavioral health challenges, whether it's from the trauma or whatever. Um, Same with custody. Like people do commit crimes and need to be held accountable for sure. And our folks that live with mental health and substance use issues are disproportionately represented in our criminal justice system.
Right.
And so is that the right place for them? We have people sitting in custody for months who have been restored to competency, yet aren't getting any kind of treatment or care. And they're just, I mean, that's a civil rights violation in my
Yeah.
opinion, and hospital is, like I read a recent report that came out about folks entering full service partnerships, and the average number of times some folks had been hospitalized before getting that treatment was over 20. The
Hmm.
average number in one county.
Hmm.
So that means
Hmm.
some of them had been in the hospital dozens of times before they actually got that care. So when we get those pieces of data, it can really inform what interventions we provide and how we respond.
Yeah. I remember we had the LPS audits, and one of the reasons why people seem to go back, from getting off, being stabilized, going off of conservatorships, and then coming back, is because of the service issue in the community. And FSPs have been um, proposed as being a really big and good solution to that. Do you agree?
I do.
Okay.
I definitely do. I mean, I think people coming back from a locked placement, whether that's a carceral setting or an IMD, should absolutely have be wrapped around in their community when they come home. Because I mean, just think about it. You're in this safe environment for months on end, and then you come home and don't have anything. You need a care team to help support you, step you down back into the community, and ensure you're successful. And there are some evidence-based forms of FSP teams, which are called ACT or FACT teams, assertive community treatment teams, or forensic assertive community treatment teams. But our full service partnership teams here in California were actually originated back right before MHSA when we had AB 4 and AB 2034. They specifically targeted people who were unsheltered and living with serious mental illness. And they, during this pilot phase, when they were originally created, they were proven to reduce hospitalization, incarceration, and homelessness, and to save the state millions of dollars. And so that's what started MHSA, and MHSA ended up passing a 1% tax on the millionaires here in California, um, all of which goes to mental health services, and proudly authored by Daryl Steinberg and Rusty Seelix and a lot of other people. And and 20 years later, after MHSA passed, Proposition 1 passed this year, which kind of changed MHSA, some of the way the buckets are spent and those kinds of things, but kept this focus on those full service partnership slots. It's now 35% of the total funding in this new model, and I think that was a testament to the state of California, the administration, and the voters' uh, kind of focus on reducing homelessness, um, and the hope that if we can target those interventions to people living with mental health and substance use disorders, we can, make a dent in it.
Okay. So, thinking about Proposition 1, it's got a lot of bond money associated with it that's going to help make sure that there's the community out there of service supports that people need. But my observation is that it's proceeding pretty slowly, which I guess is not un, you know, it's kind of to be expected because these are facilities that don't exist in some ways. Ground has to be bought. They have to build on it. They need permits to do that. They've got to go through these processes. So it's taking years. So when we talk about the ability to produce these, that's good. But the other thing that we're also moving very slowly on is the workforce, and trying to add, more psychiatrists is like pulling teeth. It's just really difficult. Um, at the end of the day, those two challenges seem to me to be the big ones, where it's like, how do we hang on? How do we get by? How do we make the best of what we got until we really got what we really want and need, right? So I guess there wasn't a question in that. That was really more of a statement. But I guess I'm impatient. One of the first things that I was told when I was starting out as an advocate was how slow the state moves,
Mhm.
and that's been it's been demonstrated over and over and over again. These are good things, but building, you know, I don't know, what is it, 60 beds in San Mateo for mental health rehabilitation centers took 10 years. So some of this moves really slow. Um, and I think that's what I was thinking, is that full service partnerships can kind of help fill in some of the blanks. So we already know how to do that. And we have teams out there. We are going to expand them with the monies in Prop 1.
Yeah, I mean, I think the answer to both of the challenges you kind of brought up is the same. It's like it's going to take us years to train psychiatrists and like to find psychiatrists that are representative of the Californians writ large, right? And if you think of the workforce as a pyramid with peers, with the peer workforce at the foundation, not because they're the least important, but because they are the foundation. They are
Mhm.
often the first place that clients receive services. They're the quickest to be trained, and can often support those different levels as we think about the pyramid on the way up. And it's no different than when we think about community mental health. Like, for sure, we may need inpatient beds in some of our counties. We might need some more. But until we can build out whatever infrastructure it takes to get to those, we can build up these community mental health services in the hopes that we can avoid those folks getting to those locked settings,
To the high
where yeah.
intensity services. Yeah. How do people seeing this, wanting to help, how do they do that? How can they get involved and be part of the effort to improve things?
I mean, there are lots of, advocacy organizations in this space. I would encourage people to, whatever they're passionate about or interested in becoming involved in, to like research the different advocacy organizations. For us, if we have a website, we have abilities to get sign up for our newsletters and to be participants in some of the initiatives, our Vision 2030 for one. We also have things like student interns and things like that. So folks that are coming up in the field that might be interested in the advocacy path
Mhm.
could join our team and get a taste of what it's like. And um, I I encourage anybody who's interested in behavioral health, feels passionate about it, to at least try on some of the advocacy work, and um, because it uses a different part of your heart and brain, and I think we need more people in this space that are passionate about it.
Yeah. Thank you. That was fun.
Yeah, thank you. It was great to spend time with you.